This conference will now be recorded.
Well, good evening, everybody. Thank you for joining us today as we introduce Dr. Rastatter to introduce you to the head and neck surgery team. We know it's been a busy day, lots going on, so I won't take up too much of your time with the welcome. So I'm going to go ahead and take you over to Monica Herron, who's going to give you a little brief introductory. Thank you.
All right, welcome everyone. We're very glad to meet with you tonight. My name is Monica Hearn. I'm the physician assistant that supports all of the head and neck surgeons that you've met today. So I work with Dr. Rastatter, who's about to present to us. We see patients at all of Lurie's locations, and we're happy to help in any way that we can to facilitate appointments or collaborations with specialists. We can do telehealth appointments. We're always available. There's one of us is always available every day to see patients on an urgent basis if needed via telehealth. So we also wanted to let you know that we have a new website. It's our head and neck page at luriechildrens.com, as well as an email address. So head and neck at luriechildrens.com is an email address that you can use if you need to contact us easily. And you can also give that to parents as well. We just want to take away as much of the red tape as we can if you need to get a hold of us. So I'm just gonna share my screen real quick because I have the updated slide for Dr. Rastatter, who will be presenting next. So Dr. Rastatter is one of our three surgeons. His focus is in everything, but specifically our skull base and thyroid practice. And you can see his information here, and I'll let him speak more about himself.
Okay, I like speaking about myself. No. All right, so thank you everybody. Welcome. I know this is being recorded, so some of you will watch it later. I suspect that'll be the majority of folks at 5 p.m. right, getting into kind of dinner time here. But for those of you that are here, welcome. And now I am sharing my screen. So I know I've been here at Lurie for 11 years, so I know a lot of you have heard me or met me, and for those of you that haven't, it's a bummer that this online version of talks these days don't allow us to be in closer contact, but hopefully we can soon, and we can kind of exchange some handshakes and high fives and get to know each other a little more personally. The other two of head and neck folks, Dr. Matalozzo and Dr. Johnson, we work very closely together along with Monica, covering the whole range of head and neck problems, lumps and bumps in kids' necks, benign, malignant diseases, and so on. And over the years, I've developed two areas of specific interest within all of the head and neck surgery, and one is the endonasal skull base surgeries that I do with Port Alden neurosurgery. We're not talking about those today, but I'm happy to talk about that another time. My other area that's of emphasis is pediatric thyroid disease. So I've been getting more and more involved with that. It's a really interesting area. Pediatric thyroid cancer is rising in incidence, as is thyroid cancer in adults. There's theories on why that's happening. We don't have all the answers right now, but I'm actively involved with our national guidelines for pediatric thyroid cancer from the American Thyroid Association. Also, it just came out with some guidelines, which was a joint venture with the American Head and Neck Society, as well as the American Academy of Clinical Endocrinology. So I've been pretty involved at the national level with guidelines and so on. And a lot of that's come with taking care of the patients, here at Lurie. So just want to talk a little bit about thyroid disease based upon those guidelines, and give a couple of cases that we can use to really kind of demonstrate the guidelines and how to utilize them. Now, give me 1 second while I try and move some of this stuff away from my screen so I can actually see my own screen. Apologize. Well, how do I move this? Okay, there we go. Let's move that way. All right, so plan today, we're going to review some of the background information of pediatric thyroid nodules and cancer risk, and talk about the American Thyroid Association guidelines, and really highlight 4 pearls that you can hopefully take home into your practices with you for managing these kids. So for many years, we've extrapolated best practices in thyroid care from adults, and that's especially true in terms of surgery. And we continue to emulate that a great deal today. And specifically with pediatric thyroid disease, there's very few randomized control trials, because it's a pretty relatively rare condition. We're talking about smallish numbers. But in 2015, we have these. We have the American Thyroid Association guidelines. These are actually being updated right now. I'm a part of that team updating them. They'll be updated within the year, and there's some more specific items coming out there, but these are still very relevant right now. So just start off with pearl number 1 right off the bat. Recommendation number 3. There's a whole bunch of recommendations in these guidelines. I'm just highlighting some key ones. But children with differentiated thyroid cancer should be cared for by teams of physicians experienced in the management of these children with differentiated thyroid cancer. This will facilitate interdisciplinary decisions regarding optimal therapy to help reduce the possibility of problems, inadequate surgery, complications. So I circled a few words there. So teams, so multidisciplinary, interdisciplinary, getting teams that focus on this, experienced people, optimized therapy. One of the challenges with thyroid surgery is the complications are rare, but when they happen, they can be really problematic. So we have a multidisciplinary team here conducting thorough history examinations, detailed review of ultrasounds and imaging studies, helps us determine the appropriateness of when to do a fine needle aspiration biopsy, and ensure appropriate use of radioactive iodine and imaging. And importantly, we provide high volume experienced thyroid surgeons. Here within our otolaryngology department, not everyone does thyroid surgery, just our head and neck team does. We try and concentrate those cases in those hands to ensure a high volume and optimal results. So we also coordinate long-term follow-up. And this was an interesting, study that was done. This was with adult data, but there's similar stuff that has come out with pediatrics data. But if you look at it, basically the number of thyroidectomies you perform per year, the more you perform per year, the lower your risk of complications. So this paper was used to push the idea that people performing under 25 thyroidectomies per year are less ideal. I don't want to say they shouldn't do them, but less ideal in terms of monitoring as measured by outcomes than folks performing 25 or more per year. So we do have that volume here at Lurie in our group. So pearl number 2 is that nodules are less common in children than adults, but they actually have a higher risk of cancer, 25% versus 5 to 10% in adults. And if you look over in this children's side here, when children have papillary thyroid carcinoma, they more commonly have lymph node involvement, extrathyroidal extension, pulmonary metastases. So basically, kids they're less likely to have differentiated thyroid cancer, but than adults. But when they do get it, it tends to be a more advanced state. It tends to be a little bit more spread, involving the lymph nodes, and requires a little bit of a different thought process when treating them. So new cases of thyroid cancer in people under age 20, it represents about 1.8 of all thyroid malignancies diagnosed in the United States. So again, less common in children than adults, but the incidence does appear to be increasing. Some of that can be explained by increased identification due to higher definition ultrasounds or increased surveillance and looking for these tumors. But even when you correct for that, there does appear to be an actual increasing incidence in the rate of thyroid cancer in kids and adults. And we don't have all the answers as to why that is right now, but there's a lot of research going on to try and figure that out. So the most common presentation of differentiated thyroid cancer, and by the way, I keep using the term differentiated thyroid cancer, basically meaning papillary thyroid cancer and follicular thyroid carcinoma. Those are the two most common in adults and kids, with papillary thyroid carcinoma being by far and away the most common. And the differentiated thyroid cancer is to contrast that from medullary thyroid carcinoma, which is a different beast. Not going to get into that here, and the more undifferentiated forms, anaplastic carcinoma, which is super rare in children, usually more in elderly adults. So papillary thyroid cancer is by far and away the most common thyroid cancer that occurs in adults and kids, especially kids. So nodules, how frequently are they? Some postmortem exams suggest 1 to 1.5% in children and 13% of adolescents. And remember, slightly higher risk of malignancy in kids than adults with a solid nodule. You do have high-risk populations, those with iodine deficiency, prior radiation. They have other thyroid disease, childhood cancer survivors who have potentially, had radiation, and certain genetic syndromes that are associated with thyroid cancer. So we'll read through those, but when you look back through this is a slide to maybe pause with and just kind of take in a little bit and understand those syndromes that come with the risk of thyroid cancer. All right, but let's kind of jump into some more fun stuff going through cases. So you have a child that comes to your clinic with a thyroid nodule. So how can you use these guidelines to help you manage this child? One, first of all, you're always welcome to call me, email me. I'm happy to kind of help through the process. But I want to kind of go through a couple of cases to show you how I think through these using the guidelines. So one of my patients is a 15-year-old male. He has a history of Hashimoto thyroiditis. After workup for excess fatigue, a non-tender lump was noted in the right lower neck, and he was otherwise a healthy guy, meeting milestones, no associated pain, weight loss, trouble breathing, swallowing. So what would you order first? I think again, when we're in person, we can do show of hands and all that sort of stuff, but over the Zoom, it's a little more difficult. But in thyroid disease, I think we all know ultrasound is as one of the more common and very useful exams to start off with. So in this child, we saw a hypervascular gland, and that red circle shows a dominant nodule in that right lobe with a maximum dimension of 2.6 centimeters. So here's a super useful table from the ATA guidelines from 2015. It's actually table number 1 in the guidelines. I'm happy to forward these guidelines on to anyone who's interested in them too. Just feel free to email me. So we have a solitary or suspicious thyroid nodule. So what is a suspicious nodule? It's solid or partially cystic nodule where the solid part is greater than or equal to 1 centimeter, or it has concerning ultrasonographic features, calcifications, irregular borders, wider than tall, those sorts of things. This is what I like to emphasize is that one of the first things you want to look at when you have the nodule is what is the TSH level. I think sometimes people will jump right to, oh, there's a nodule, let's think about biopsying it. First, take a quick peek at that TSH level, and you'll see why momentarily. In this child, the TSH was elevated. So we have a hypervascular gland, dominant nodule, elevated TSH. So we're going to come down on this algorithm down here, and that actually does lead you toward FNA under ultrasound guidance. It's important to do this under ultrasound guidance. You'll find some folks out there that try and do FNAs by just feeling the nodule and putting the needle in. We always do them under ultrasound guidance here at Lurie. It's way more accurate. The interventional radiologists are excellent at hitting even very small nodules in thyroid glands. You can also take that opportunity if there's concerning lymph nodes to sample them as well. So in this particular child, the needle biopsy showed a Bethesda class 6, which is consistent with papillary thyroid carcinoma. So coming over here from the FNA, it leads us over to a malignant lesion. So what do we do, with a malignant lesion in children? The recommendation is for a total thyroidectomy. Now that may seem obvious, but it's actually, this is something that's under a lot of debate. In adults, there are some low-grade, well-differentiated cancers, small, well-encapsulated, where they're actually doing lobectomies or hemi-thyroidectomies in adults. That's starting to come up with kids, and we're going to address that in the newer guidelines that are coming out next year. But as of now, the recommendation is still total thyroidectomy. It's because of a relatively high incidence of bilateral and multifocal disease that you find on pathology. Should all thyroid cancer cases have at least an ultrasound of the neck specifically to look for adenopathy? The guidelines would say yes. You don't want to go just on an ultrasound of the thyroid. You need to have a specific thyroid or a specific ultrasound looking at the neck, looking for suspicious nodes. So that's pearl number 4, a comprehensive neck ultrasound. We have a specific ultrasound that we order called a pre-thyroidectomy ultrasound here at Lurie, where it does full node mapping, trying to get a sense of where is all of the disease so we can plan one procedure and get it all done and preferably not have to go back. Biopsy of suspicious nodes is recommended, additional imaging in select cases. So here, the examination of the neck did not show any suspicious nodes. So this child ended up having total thyroidectomy, and there is, a picture of his thyroid gland. Gotta have pictures in surgical talks. He did well afterwards. We always look at the PTH levels after surgery because despite taking extra care to preserve those parathyroid glands, sometimes they can be stunned and you can have some temporary or rarely permanent postoperative hypoparathyroidism and low calcium levels subsequent to that. This child's parathyroid hormone level was normal and he was discharged home on postoperative day number 2, doing well and did not require calcium supplementation, but certainly required synthroid due to his whole thyroid being removed. So here's the pathology. That's what the pathology of papillary thyroid cancer looks like. Fortunately, as primary care providers and surgeons, that's about all we have to say about that. The pathologist would probably wax lyrical about all those colors and everything else, but that is what papillary thyroid carcinoma looks like. Now, this child did come back, final pathology consistent with papillary thyroid carcinoma, and that second bullet there, multiple microscopic foci involving both lobes. So that's why we struggle with thinking about doing a hemi-thyroidectomy in kids, because they have a high incidence of this this microscopic bilateral disease. Now, this child's initial nodule was too big to be considered, even by adult criteria, considered for a lobe anyway. But that's what we're kind of concerned about, is this bilateral multifocal disease, of why we recommend total thyroidectomy. He actually had some lymph nodes involved as well. Post-operatively, what do? We have a whole plan that our team comes up with for following him with neck ultrasounds, making decisions about radioactive iodine, making decisions about further surgery, and developing a long-term monitoring plan. So all of these things are kind of done by the team to try and get kids to have ultimately have great outcomes, cure them of their disease with minimal morbidity, protect the recurrent laryngeal nerves, protect the parathyroid hormones and or glands, and try and get as comprehensive a surgery as we can up front by doing the proper evaluation, such that we don't have to keep kind of going back because potentially the neck wasn't comprehensively looked at up front. So that's a case kind of going through those guidelines. I want to show a little bit of this presentation of this case number 2 to kind of contrast a little bit of why that a couple principles and one to really think about as I go through this is why I emphasized on that last case really checking that thyroid stimulating hormone level right up front. So this is another patient of mine, a 17-year-old female, right neck lump noted by parents. Again, otherwise healthy, meeting milestones, no associated pain, weight loss. Otherwise, perfectly healthy teenage woman. So same step first. We get the ultrasound, and she's got a cystic and solid mass occupying the majority of the right side of her thyroid. Maximum dimension 3.6 centimeters. She also had a 1 centimeter smaller nodule that was more cystic on the left side. Scanning of the neck, no lymphadenopathy was evident in the neck. So we go to these guidelines. So we're same place in the front. We have a solitary or suspicious nodule because it's greater than a centimeter. Now here, what's going on with the TSH? We take a quick peek and lo and behold, the TSH is low. Interestingly, she has normal T3 and T4. So she is euthyroid, normal thyroid hormone levels, but her TSH is suppressed. You can have hyperfunctioning areas of your thyroid gland that will drop your TSH level before they present with elevated T3 and T4. So the TSH is the most sensitive way to start to pick up on this. So here, with the TSH suppressed, the next step that's recommended by the guidelines, and I agree with them, is a nuclear thyroid scintigraphy, so an uptake scan or a thyroid radioactive uptake scan. The reason we don't proceed right to FNA here is hot nodules or active areas of the gland are way less likely to be cancer than a cold nodule. So a cold nodule where you don't have suppressed TSH and you have suspicious features, that's what leads you to more of the FNA. But when you have suppressed TSH, you're worried about a hyperfunctioning nodule, you go towards nuclear scintigraphy. So that's what we did here, and that's what she had. You can see over here, this is the lower right portion of her thyroid gland, and you can see this increased uptake with all these time sequences here, consistent with a hot nodule on that right side. So it's a hyperfunctioning nodule. What do? We go to surgery for this, but now what surgery is that? The surgery is not a total thyroidectomy here. We're not really concerned about cancer because it's very, very rare in a hyperfunctioning nodule. So you can do a lobectomy here. So we take out the lobe, preserve the other side of the thyroid gland, and then potentially this child is not going to need thyroid hormone supplementation afterwards. A hemi-thyroidectomy is significantly less risk than a total because you're only exposing one recurrent laryngeal nerve and half of the parathyroid glands to potential risk. So recommend surgery to remove the hot nodule, typically via hemi-thyroidectomy, also referred to as a lobectomy. So in here, I'm just emphasizing again, you do not necessarily need to do an FNA if you're suspicious of a hot nodule, at least up front. It's not wrong to do it, but if you're following the the guidelines and going with what's next, the next best step would be an uptake scan. So in this particular case, though, well, what about the other side? There was a smaller one on the left side. Sometimes you can approach these independently. So that other side, we have TSH suppressed. We did our nuclear scintigraphy. It was not hyperfunctioning, that one. It was hypofunctioning. So even if your TSH is suppressed and it's hypofunctioning, you would proceed to FNA in that situation. So she did have an FNA of that smaller one on the left, and it came back as benign. So all of this extra thought and workup allowed us to make the decision to do a hemi-thyroidectomy in this child and monitor the other side with a very small benign FNA nodule. The benefit being she had a less risky procedure and did not end up needing thyroid hormone replacement. So surgery talks, you have to have a little video too. So there is the half of her thyroid gland with a stitch mark at the top, and that big lump that I'm holding there with the forceps is the hot nodule. That's what it looks like chopped up on pathology. Here's some more fun pathology slides. And this came back as a hyperplastic thyroid nodule with cystic degeneration, but no cancer. So she had a very large nodule, but because we followed the guidelines and came down these guidelines and really thought this through, we were able to do a hemi-thyroidectomy, save the other side, and she's been doing well. This girl is actually a couple years out, and she has not needed the other side taken out. That other small nodule on the other side remains very small and non-worrisome in appearance. She also did well postoperatively, went home the next day. No synthroid, so no thyroid hormone replacement, no calcium supplementation because we saved of her gland. And then she has a postoperative follow-up where we're just kind of monitoring her. Now, it wouldn't have been wrong to do total thyroidectomy. I actually offered that as an option. This was a very intelligent family who understood the options. Mom is actually a physician, and they elected to do this procedure of the hemi-thyroidectomy, which was very reasonable, and it's what I would have chosen for my own daughter. And now we're just kind of monitoring that other side. Repeat ultrasound of 6 to 12 months. So summary here. So pearl number one, pediatric thyroid care should be ideally performed in a multidisciplinary, coordinated fashion. Pearl number two, nodules are uncommon in children, but more frequently are malignant, 25% compared to more like 10% or less in adults. Pearl number 3, fine needle aspiration of suspicious non-functioning nodules under ultrasound guidance should be performed prior to surgical resection in most children. Number 4, comprehensive neck ultrasound, looking at all the cervical nodes in addition to the thyroid gland when you're suspicious of or you know based upon FNA of cancer, so that you can plan a comprehensive procedure involving neck lymph nodes and thyroid surgery at the same time. I think one slide may have dropped off there because I like to have the Pearl too. The other Pearl that's not on there is the one I emphasized, that TSH level, super important. When you have that child where you find a nodule in their thyroid gland that maybe you palpate, you get an ultrasound, you see that nodule, look at that TSH level and see if it is suppressed or not. And that's going to help you move toward an uptake scan if you have suppressed TSH, thinking that you might have a hot nodule, or a needle biopsy if the TSH is not suppressed, leaning more towards a cold nodule. So thank you. And it was kind of a run through some of those guidelines. There's many more guidelines there. I'm always happy to speak with any of you when you have these patients with thyroid masses, lumps, bumps, Graves' disease, all thyroid diseases. It's an area I really enjoy working with, and I'm happy to help with any questions you have about your patients.
So that was absolutely outstanding. Thank you so much.
Oh, no problem.
What a wonderful presentation. I'm sure everybody got a lot out of that. You know, I encourage a lot of questions here, and we already have one in for you. So in the chat room, so it's asked, can PCPs order a pre-thyroid ultrasound? And is this preferably done at Lurie or a community hospital?
Very great question. The pre-thyroidectomy ultrasound is usually, right now, it's sort of restricted to only a few people can order it, mainly because it's a longer ultrasound that takes, it takes like an hour of the tech's time. It's a really involved ultrasound, so we're trying to make sure it's ordered appropriately. So in those kids that where we're more suspicious of the thyroid cancer versus not. And yes, it is only being done at Lurie downtown right now because they have the highest definition ultrasound machine there. Now, ideally, we're going to get those machines at other locations soon, but you know, this is also, thyroid cancer is sufficiently rare that I've found that the families, even the ones that live a little, you know, maybe up north, with the particular diagnosis of thyroid cancer for which we're getting that ultrasound, they usually understand, okay, I get it, you know, yeah, let's go downtown for that. But that being said, I would like to be able to do that more involved, high definition pre-thyroidectomy ultrasound at other locations soon.
That's great. Thank you. We don't have a very large crowd tonight, so if you have other questions, feel free to unmute yourself. And
while we're doing that, Monica, can you pop up that summary slide of mine that has the, you know, my email and all that?
I have that available.
Do you have? I updated a little bit with. Yeah, there it is.
Mm-hmm.
Or actually, Monica's was a little bit. Do you have yours, Monica? Go ahead and switch it over to.
All right, that's fine. I also put your contact
I thought we had the updated numbers on there. We'll say that feel free to J Rastatter, Lurie Children's. Or email me anytime. I find that I know, you know, the phones these days, we get so many robocalls on those things. You never know whether it's, you know, a human being calling or some robot trying to sell me something. So I check my email all the time. So that's a quick way. Monica also mentioned that head neck at LurieChildren's.org. That is a mailbox that goes directly to Monica, and then she kind of filters them out to myself and Dr. Matalozzo and Doug, and it's just depending on what it is. But always feel free to email me, you know, directly, and and that's oftentimes the quickest way. There's also my Northwestern email on there as well. And as soon as we can kind of fix the robocall problem, we can all go back to phones again.
I hear you. I will also be sharing this information via email to everybody as a follow-up, either this evening or tonight. So I'd ask everybody who joined us today that when you receive your email from us with the link to the videos that we presented today, we encourage you to share it with your colleagues who are able to attend, so we know how busy your schedules are. But just want to thank you both for joining us today. This was great, and we look forward to doing another one with you.
Yes. Thank you everyone who joined now. Thank you everyone who's watching the recorded version. Again, looking forward to the time we can do these in person together again.
All right. Thank you. Everybody have a great evening.
Okay. Bye-bye, everybody. Take care. Happy Inauguration Day.
That's great.